Hi guys, and welcome to Wemcast with me, Eoin Walker. I'm back today speaking to a colleague and friend, Matt Walton. How are you, mate? You all right?
I'm all right. Thank you very much for having me again.
No, not a problem at all. My pleasure, my pleasure. So, Matt, just for people who might not have caught the first episode of me and you talking together, just for listeners, could you just give people a quick background of what you do and what your role is at the moment within the NHS?
Yeah, sure. So I'm Matt Walton. I'm an A&E doctor working in London, which in this context is one of the worst affected areas by the coronavirus outbreak. And so I thought hopefully we can have a chat that'll be as useful as the previous one was and give some insight into what the situation is.
That's brilliant. Absolutely fantastic. Absolutely, Matt. Absolutely. So, just looking at where you are now from where you were a couple of weeks ago, just within the current climate and within your colleagues, and just within how things might have changed. How are some of the dynamics at the moment, Matt?
So I think overall, we're probably just kind of getting to the point of exhaustion and tiredness now. It's been a number of weeks sort of working through the peak of the virus. And I think it just yesterday that there's been announced that there's been 15,000 deaths across the UK. So there's been an enormous amount of super unwell patients coming into the emergency department. Some unfortunately have died, and we've had a huge amount of deaths in and out of the hospital. A lot of our colleagues and staff have been off sick in massive numbers, and unfortunately as well, we've actually had some staff deaths, which is tragic. And despite that, people are still working. They're still showing immense bravery and immense resilience to continue. And I suppose we are then seeing some positive signs of the lockdown working and the case number starting to actually fall coming into our emergency department. So there is some still level of hope, but I think people have kind of been through hell really in the last few weeks.
Gosh, listen, we'll touch on all those points because I think all of them are really valuable points just to unpick and just to do a deep dive on. But just to notion towards a sense of coming into sort of more of a familiarity with PPE and this sense of routine and almost ritualistic practice from start to end of shift. Is that something you've kind of had to? Is that almost a new normal for you?
Yeah, exactly. So I was saying the other day that we were actually all marveling at a chest X-ray that just said normal radiograph as the report, because we've seen so many chest X-rays that are just horrific in appearance with coronavirus, and it had almost become that was the only condition we'd seen, to the point where you were almost worried that people with other conditions weren't coming in, like heart attacks and strokes, and were staying at home. But I think some things, as you say, in developing a routine have been helpful in reducing the stress. So we've had a lot less daily changes of guidance on protective equipment and structural changes in the organization and changing areas where we're working daily, it's helpful, and things like, if resources permit, I've got a waterproof case for my phone at the end of the shift now. If there's a chlorine wipe available, I'll try and wipe everything in my visor, change my shoes, put everything into a bag in my locker, go home, shower, take all the clothes off, and kind of decontaminate to then get back in the house. And I think that kind of developing a routine around that has been helpful. And then also it's important to remember as well that though there's some things that are helpful about the routine, then obviously the routine is a routine of abnormality and of sometimes even onslaught of back-to-back intubations and palliations and really, really sick people. And I think that that's a routine that isn't pleasant at the same time as well.
Yeah, absolutely, Matt. Absolutely. So, just before we do a deep dive into some of the sort of extreme physiology that you've seen around saturations and patients desaturating, just notioning back towards the level of fatigue that you've been experiencing and the team's been experiencing, um, it must have you must have seen the attrition of both human factors and just personal fatigue, just having to, like I said, live in PPE, but also just do extensive shifts in and in a climate which has got a high acuity of really sick people, um, has that lent itself to almost the longevity of just chronic fatigue almost?
Yeah, and I think you sort of wonder at this stage, what will the end point be, and how possible is it to sustain that level of working, and hopefully it will start to level off, but I think people now are going to be showing those signs of kind of reaching almost a breaking point, I'm sure, and have a lot of things that they've sort of shelved in order to keep moving and keep going forwards, that they really kind of need time to address and process. And I think it's not normal for any of us, and we have to recognise that the frequency of extremely unwell patients will have a toll, and I think that especially just even wearing the kit all day is just tiring and just exhausting.
Yeah, absolutely, Matt. So just pivoting slightly now and actually looking at some of those cases. So looking at some of the sick cases again, has it become a new normal to see some of this extreme physiology that you might actually be akin to sort of high altitude medicine with extremely desaturated patients?
Definitely. So I was trying to look up to sort of contextualize how unwell and how low the oxygen levels are in people that we're seeing, and some of the worst cases that we've seen who come up to A&E and are still just about conscious have got saturation sort of in the 50s, which to contextualize for someone who's not used to that is the same as roughly what was measured on Mount Everest at the highest point, from arterial samples of climbers where they've recorded the lowest levels in existence in the world. um, and and these patients obviously are sick and are what you would call peri-arrest, as in any moment they might go into a low oxygen cardiac arrest where the heart stops because of the low levels of oxygen. And sometimes there's overt skin changes and widespread mottling of them. And in one case in particular, I remember it was literally a case of holding the oxygen mask on their face and doing what we call proning, which is a positional change to put them chest to the table, to change the dynamics in the lungs, which is meant to help slightly, and literally just holding the mask on their face and willing them to breathe. And out of the corner of your eye, then you've got the team who are getting prepared outside of the isolation room in order to do the risky procedure with that low oxygen level of intubating the patient, which is the process of putting them onto a ventilator. But in a few cases, then we have seen that they, over a few days in intensive care, have actually improved. And that's an extreme example of pure life saving in action, where if every step of that chain, from the paramedics picking them up right when they did at home to them coming in and receiving the treatments they need and then going on a ventilator, didn't happen exactly when it did, then they for sure would have died. So that's a good example of how we're able to still save people. But equally, as I'm sure many of our pre-hospital colleagues and colleagues on the wards and in intensive care will know, that the death rate is actually extremely high when you're kind of getting into the need to be ventilated type situation.
Yeah, absolutely. Just from my own experience, really, over the past few weeks as a critical care paramedic, those those cardiac arrests that have gone, have fallen off the cliff and gone into cardiac arrest, it's almost 100% mortality, really, because there's just, because of the underlying respiratory pathology and underlying comorbidities of asthma and or COPD, just chronic respiratory disease. In a lot of the patients, it does compound the fact that we're not getting, we're not really seeing any return of circulation in this patient, and it's very difficult. So to sort of pivot slightly, Matt, and look at the really difficult and challenging part of that. I know you said before, and we were speaking just earlier about some difficult conversations when patients are coming in and they're either being ventilated or have got really low saturations. Are you seeing that difficult conversation around palliation, around just around what do you want for your loved one a lot sooner in the patient journey?
Yeah, definitely, and I think as I said, I can't really imagine what that must be like in the pre-hospital field, and I'm sure it'd be good to hear about your experiences as well. But a lot of the patients, I'm getting used now to having these conversations with them extremely early, and to the point where sometimes if there's a short delay with them getting it into the hospital, I'll even be proactive and be going out into the ambulances, and once I've found out the other information medically that we need, if I'm looking at the person and if it crosses my mind that there's a real chance they could deteriorate and die over the next few hours, I'll make sure I try and have that conversation with them there and then, whilst they're still conscious, because it could be the last opportunity. And that involves mainly trying to understand them and understand what their priorities are in that situation, and kind of if it's appropriate to do so, sharing that thought with them that it could be a terminal event. Um, and and I try to write down everything that they say at that point, because it could be the last record of it. Especially, obviously, family comes up quite a lot, and if they have, if they say something nice about their own family, or if they want to be speaking to someone and want to have someone on the phone at that time, trying to make those things happen. And then daft things like a patient wanted some ice cream, and so we kind of made a special effort to send someone around the hospital running to get them some ice cream, and that kind of thing. But then of course, you just get the tragic and very poignant moments where all you can do is kind of hand holding and stroking a person's hand and being that, I suppose, that family for them that they don't have in that situation, and that's incredibly impactful, and it strips that dynamic away from you as a clinician in your protective equipment and the person, where you're just two humans really. And I think obviously that is a privilege, and it's incredibly sad as well, to have that sort of situation happening, and if that happens so regularly, I guess that is going to have an effect, that kind of situation happening so regularly. But I'd be really interested to hear what your experience has been like in the pre-hospital environment.
Yeah, so very similar, really, Matt. Actually, having early conversations with family members, with next of kin. It's been really quite truly difficult, actually, especially getting there as a critical care paramedic when the patient's already died, because it does carry such a high mortality rate. I was just confronted with lots of death notification messages, just breaking bad news, over these past few weeks, to the point where some of them I've not been able to tell. I've been able to tell the next of kin, the wife or the husband, but I was stood in front of three beautiful, lovely young daughters. Ages between 5 and 12 years old. And they wanted to know how their daddy was, and I just couldn't actually convey that message to them. The mother didn't speak any English; she spoke a foreign language. They spoke perfect English, and it's situations that you're sort of parachuted into like that there's almost no words for sometimes, and
Yeah.
I managed to convey to the wife and get her on side and use a translator, but it's crashing through situations like that 5 or 6 times a day, that just is extremely difficult, actually. And I did a shift in the control room yesterday, and I'm actually working tonight in the control room. And what we're seeing at the moment, Matt, is a real proliferation and spread within the care homes and nursing homes. And actually, that's really difficult because um, there's a lot of palliation that needs to take place that might not have been put in place, and actually we need emergency procedures because these people are polymorbid. They've got multiple comorbidities. They're old. Maybe they've not been had a do not resuscitate order, but it actually needs to be the case, and or otherwise. So each situation is unique, but when you're getting 5 or 6 of these difficult conversations on the phone yesterday, I was having to make and or escalate some of these really difficult situations and conversations with paramedic colleagues, I had to take a little bit of time out actually yesterday, because it was literally, almost on the minute, every minute there was another cardiac arrest and or palliation case within another care home, because there's almost thousands of care homes within London, and we are seeing the spread at the moment. And as you know, Matt, cardiac arrest is not formulaic. Our guidelines are formulaic and sequential, but patients aren't sequential. They're actually everything but sequential. They can deviate from guidance, deviate from norms. What was a non-shockable rhythm is now shockable rhythm, is then a non-shockable rhythm, is then has then got underlying pathology, which hasn't been. There's a lots of it's not straightforward, and it's not simple.
Yeah.
And to your earlier point, it adds a lot of stress, because you can't almost, you want to give that patient as much as possible, and not necessarily a formulaic approach. But you're right, it's as to our earlier conversation, it's much more like wartime medicine, because we're seeing just a higher caseload, where junior paramedics now should see one cardiac arrest every 6 months to a year. They're seeing cardiac arrests every shift. And I'm used to seeing cardiac arrests every shift, but the frequency and the emotive situations you're being placed in, talk about a time really to truly become mindful, and to really sort of let things go after a shift, because if you carry things through. So just before I just ask you another question, actually, we're actually seeing a higher rate of mental health within the community, even to the point, some of the things I actually can't talk about on the podcast, of some of the suicides I've been to, and hangings and other forms of suicide. But there was even some NHS workers over the past few days have committed suicide, which is just shocking, really, and harks towards not only the actual stress that we are under as clinicians, but just the social situations they may be living in, the stress that they may be feeling, the arduousness of the tasks, the human factors, and that's been really difficult to see that from a clinician to clinician perspective, when it's some of our colleagues. And I know you've had because it's not necessarily been a suicide, but there has been a death of some colleagues. Am I correct in saying so?
Yeah, and I think it's just it's an awful situation, isn't it? And I think just to touch briefly on what you're saying, I think there's just such difficult working environments, new and extremely difficult decisions to be made regularly, and ultimately at the end of the day, if you don't care and you're not affected in some way, then that is probably a sign that you're human, the fact that you are, and that you still care. So it's so important that I think, as we're doing now, that we just talk about these things, and that, if you're really getting down, actually to know that that's quite normal in this situation. It's a normal reaction to abnormal events, and the most important thing is just talking to someone about it. No matter how you're feeling, they'll listen, and it'll be helpful. But yeah, we've had a lot of staff absence, an enormous amount of people who've been off sick, enormous colleagues just dropping like flies, and that comes with a lot of anxiety about your own welfare, and kind of making preparations for becoming sick yourself, and protecting your family members, and people you live with and care about, and then we've unfortunately had a number of deaths in our organization, and I think I'll kind of cover one of them, and I think we have obviously talked about addressing this subject because it's such a sensitive subject, but equally I think we're both agreed that we shouldn't try to shy away from it, and we should try and talk about it because it's part of the reality, and we owe it to mention it. But I think, yeah, it's an awful situation if a colleague or another NHS worker has died, and I think your heart immediately goes out to their family and the just tragic situation that they found themselves in. And I think I thought I'd try and share some observations on that, which might be helpful and productive to go through. And that's so I'll, without obviously identifying the person and being really sensitive to their situation. So when I'll start with when we were told about the death of one of our colleagues, and that was with a few of us in A&E in the middle of a shift. And one of our colleagues came up to us and essentially said the name of our colleague and told us that they had died. And I think when you receive that news, at first it obviously just seems unbelievable, because you're talking to them just a week or two ago, and they were so very much alive, and it's not normal. It's not what's supposed to happen, and then obviously with a few follow-up questions to try and verify that news and try and understand if that really is true. Then I think all of us kind of sat there in silence, and some people welling up. And I think something to be aware of, if in that situation, if that does happen, is your ability to be safe for the rest of the shift. Because I think if you're being delivered such a horrible piece of news, and I'm sure equally if other really grim things are happening in the middle of the shift, then just being aware of the effect that will have on you, and trying to make sure that you're safe to continue the shift, because often it's not practical to pull out of the shift, and you're not able, and you're not permitted to have a kind of an emotional reaction to it. But having said that, obviously the reactions of individuals are mixed and varied, and we had people who were in denial and got straight back on with work, who were visibly full of emotion and sadness and grief, who are the people who are furious and angry, and I'm sure you can imagine why, and the elephant in the room is sort of the word preventable, and thinking of about regret and all these what if questions, and not that that's necessarily true, but obviously it's what is on people's minds, and then thinking then to themselves and their own families, and thinking, oh well, it could be me next, and I've got a wife, or I've got children, and I've they can't afford to lose me, and I need to be as careful as I can from now on. And then then I'm sure everyone goes home and deals with it in their own way, and people who are closer to that individual, I'm sure, will be impacted more, and of course their family. And then afterwards, we got an official email saying that and confirming that, and I'm sure most people weren't really believing it until it was confirmed officially. And then after that, people, I suppose, kind of stopped mentioning it and stopped bringing it up, and of course initially there's everyone kind of telling their stories and trying to remember the person, and that is a little confusing on the face of it, but actually talking to another colleague who is in the military, they've kind of helped me to understand it, in that it's part of a coping mechanism of a bunch of individuals who are still kind of in the firefight, so to speak. They can't afford to lose focus, otherwise it could be them next. And they still have a job to do. There's still more patients to see, and those who are salvageable. So I think people might, after a while, stop bringing it up. And I think I even had some nightmares about actually delivering that news to other people and other colleagues, because it's so impactful for them and so hurtful and so affecting that you almost don't want to be the bearer of that news to another individual. But I think the thing that we need to be aware of, and another observation, is that we simply have not had the time to adequately grieve or process that situation at all. And I think that's another thing to be aware of, if that is something that unfortunately we've had to experience, being aware that actually we won't have had any time to process this properly, and possibly following the example that the military have, in that they have moments created and memorials and spaces where teams can come together again and have that moment sort of after the firefight is over, and after there's a bit of time to sort of permit people to to experience that emotion that they've been deprived of in that first instance. So I think they're kind of my observations on the topic. But I think, at the end of the day, it's just awful for everyone, really. I think it's not really.
It's tragic. It's tragic, Matt. But listen, that's a really powerful and precious recollection, actually. And whilst not going into details, it still is very honest and transparent. So I thank you for that, because it's I think you're right. In this time, it's valuable to be honest about recollection and just give people a real perspective of what it is like on the front line, both from an in-hospital and pre-hospital perspective. So I think that's so looking at that, Matt, and I think you make a valuable point about having time to process things, and just flicking it round slightly on its head. I know one of your, someone you've been speaking to, and someone I love dearly, is a colleague and friend of ours, Esther Murray, and also Mike Christian and others. So Esther looks at the process of moral injury, just having to come to terms with things that you may never have actually been trained for, might never have actually psychologically prepared for, but actually come face to face with for the first time in something like a pandemic, in something where there's quick succession of very, almost quite devastating circumstances and or events. But I understand you're writing an empirical paper right now, or have done, with both Esther and Mike. What's that about, Mike?
So we've had the opportunity extended to us to try and produce a piece of work that essentially tries to answer the question: how on earth do you actually support staff who are going through all of this stuff at this time? We've tried to create something that is useful and pragmatic and practical for organizations, for teams and individuals. And so the first thing we did was look at previous research on the topic, and we've seen that actually almost to some comfort, the experiences that we're all having now, the good, the bad, and the ugly, are all similar to what's been experienced in other pandemics and disasters. And for example, in the Toronto hospitals, in the SARS outbreak, or in swine flu, and in Ebola, these concerns that we all have and these experiences actually have been had before, and there's lessons that we can learn from them. So we've tried to capture some of that, and then kind of, as you say, go into some of the pathology and explaining, what is moral injury, what are acute stress reactions, how high would the rate of PTSD be for people going forwards, and then try to split it up into what we as individuals can do for ourselves and about that self-care, what we can do for our colleagues, and what we can do if we're leaders in teams, and then also what organizations can do. And I think, little things like making sure that you do have a plan for if a colleague or a staff member does die, and how you can support them and their family, and how you can support the staff who are remaining, and then lots of other things that hopefully we'll find it will be helpful for people to read.
That's absolutely fantastic. So yeah, it's addressing individual needs, team needs, and organizational needs, which I think is a fantastic way to break it down, Matt, actually, because you can then really start to address from a personal level to almost a global level, or certainly a collective level, your own needs, team and organization. I think that's a fantastic way to break it down, mate.
Yeah, so hopefully that'll be useful. And I think there's examples at all levels of things that we can do. For example, in our organization, our consultants have been incredibly proactive and really excellent, actually, at trying to change the structure of the organization and our work environment in order to make us better. And I think the first thing of a responsible organization is to look into themselves and think, actually, what were all the things that were stressing people out first before this even came? And that's, shift working night shifts, resource capacity demands that already exist in corridor medicine, and food and drink, not providing milk or tea facilities. These basic things that are actually the things that are going to be more important in people's mental health and existence at work than any individual factors that they can bring. And then trying to tackle those, and then also think about what are the new issues. And protective equipment is a good example of that. The first thing that you can do to support staff mental health is make sure that you've got good protective equipment available. And then the sort of icing on the cake is developing sort of programs where you can catch staff if they then become ill, like psychologist support and that sort of thing. And then team factors, so looking at leadership and what characteristics leaders can bring to the table in order to support their teams, and then looking at colleague factors. If you're a colleague of someone, just what signs in them that you can spot if they're they're not okay, or if you're worried. And essentially the message is just to talk to someone about it and just seek some advice, and then kind of just talk to them and just be reassuring, be consistent, be kind. And then going on to the individual factors, what we've discussed before is just going to the basics of like what normally works for you, and trying to address those basics of sleep and food and exercise, hydration that are probably missing, and trying to just go for that. And also talking to friends and family, and I've found that really useful myself earlier in the week when I wasn't feeling as very positive, that actually just going outside, going on a walk in the sunshine, talking to a few good friends, like that actually really cheers me up, and that's useful.
Yeah, that's fantastic, Matt. That's fantastic. And like you said, it's almost a toolkit approach, which is something we need to adopt almost, because it's fantastic to have sequentially 5 or 6 different things you can do for yourself, for your team, or indeed for your organization. And even as we said previously, having a 10 for 10, having the first 10 minutes of a shift to really illustrate the next 10 hours. Right, guys, this is how many patients we've got in the department. This is what majors, this is what research is looking like, this is what minors is looking like. This is how many patients we've seen in the last 12 hours. These are the underlying issues. But having that 10 for 10 and just really almost sharing the mental model. And we have the 10 seconds for the next 10 minutes in pre-hospital care, because as you know, pre-hospital care is a distilled version of in-hospital care. And it's like a microcosm of what you might see over a protracted period. So instead of having 10 minutes for 10 hours, we have 10 seconds for 10 minutes. And I'll say, guys, right, everyone around, okay, we've done A, B, C, D, E. What do we need to do now? Right, we haven't done this, we haven't done that, we haven't done this. And so it's a microcosm of what you might see. And it's but really useful because it gets everyone on the same page. Everyone then has situation awareness, and then everyone can then go forward with a sort of a ubiquitous mind frame of what we're trying to achieve, which is really useful. But Matt, just pivoting slightly, because I think that's really positive and really useful, and it's a really that kind of toolkit is necessary. So looking at how the nation's responded through this pandemic and since we last spoke, there's a few fundamental things of appreciation which we probably both noticed. What have you sort of noticed over the past couple of weeks and a month that the nation's done?
Yeah, definitely. I think it's obviously really important that we try and focus on some positives, and I think that the nation has definitely provided those. So I think, firstly, just the small things that everyone's been doing by adhering to the lockdown, I think is actually the most important thing that people have been doing, because that's not, it's not glamorous, but that is actually reducing the caseload, and we're seeing that now in A&E. That's great. And then obviously then there's the more dramatic things like when you're sitting on a Thursday, and then suddenly hear a clattering of pans outside, and then you go outside, look out the window, and the whole street's erupted. And then that's really nice, because you can take a moment to sort of wave at people like the Queen and and hold up your like this. My sister sent me this as a little postcard, which just says "Thank you, Dr. M," and things. Just all those little things are lovely. And I think the other things like some of the offers and the deals that have been available to us, some of the little helpful things like car insurance, the excess being taken away just helped me because my windscreen is smashed recently, and little things like that are practical and tangible and are really helpful. And then there's been other lovely moments, like especially in the light of all of the sadness and the death that we've had. It's made those moments of recovery so special, and having patients leave the hospital now, and having staff members who we've seen admitted and treated, then leaving healthy and fit is just they're extremely special as well to have. Yes, there's been a lot. There are positives in this situation that we can find and that we can appreciate. Yeah, and I saw it just as a nice quote. I saw that I've written down. The Captain Tom Moore, who is the World War II veteran, who's been. Yeah, I think we can all say thank you to him for his epic work. Going up and down his garden, raising millions of pounds for charity, and I think he's someone that has been through a lot himself, and something that he said was, we have to carry on and remember that things will get better. We've had problems before, and we overcame them. We will overcome this, and I thought that was quite a nice thing that he said.
Yes, and that's fantastic, and that's probably a really good place to leave this conversation. Just before we do, because that's a lovely quote actually, and I think it means a lot from someone who's just approaching his 100th birthday, who's lived through, was probably born when the Spanish flu in 1920 was still here. So he's lived through 2 world wars and a pandemic already, probably more than one pandemic to be honest, but it's fantastic. So just to finish off, Matt, just for another sort of message to the community really, because I think it's powerful from being on the front line, that not only is this conversation positive, it's just that you've weathered some of the waves, and actually which you have done really well. Have you got a message for the community just as we sort of come into land, as we're in the next stages of this pandemic?
I think it would just be thank you for all of the incredible support that we've received, and it does the little things that people have been doing, and the real meaningful shows of support that people have had, and respect for NHS staff, and appreciation, and everyone else who's involved in the effort, and all the other healthcare workers and people affiliated with the situation, key workers. Has been pretty amazing, and I think ultimately the real important thing that people are doing is adhering to the guidelines of staying at home, and that is really making a difference in the hospitals. And we have seen over the last week the cases that are coming into A&E are starting to drop now, and that's all due to everyone else who's been at home and doing their part. So thanks.
Yeah, listen, that's powerful, Matt, and it's almost as powerful as the mustache, which is equally as powerful.
I should actually explain that before we go in that. Obviously, it's nothing else but a cry for help, but I think it's also actually a practical tool, because if you forget to wear your mask at any point, people are much quicker to point out your horrible mustache than they are to pointing out that you're not wearing adequate PPE. So actually, it's a little safety net for me.
Mate, that's brilliant. That's absolutely brilliant, Matt. You're an absolute legend, and I always love chatting to you. So let's touch base again, and but thanks ever so much for your time today.
Yeah, thanks a lot, Eoin. It's lovely to speak to you, and keep well, keep safe.